Hello, Frederick Community College biology students. It is my privilege today to introduce to you Dr. Donald Fine. Hopefully you have met him before at the STEM Learning Center. Today I'm going to be asking him questions about the coronavirus. Thank you to my students who sent in questions. Hopefully we'll get those answered for you today. So Dr. Fine, I am not the only person who has contacted you to be an expert on this topic. So could you please share with us a little bit about your background?
Okay, I'll be more than happy to do that, Katie. I was trained as a microbiologist with a specialty in virology at Penn State University. And after graduation from Penn State, I moved to Frederick and took a job at Fort Detrick. During those days, Fort Detrick was the Center for Biological Research on infectious diseases. And so I was hired as a virologist. And once Fort Detrick was closed down as a military research center, I went to work for the contractor in the National Institutes of Health in Bethesda. And on that contract, we were studying the likelihood that a virus could cause cancer. And the work that I did along with a number of other investigators determined that some of these viruses that were thought to cause cancer actually were involved in the development of an AIDS-like syndrome in primates. And so some of my sort of pioneering work was in understanding the horizontal, which means transmission from one individual or from one monkey to another of these viruses. Later on, I came back to Fort Detrick and worked with the National Cancer Institute and was responsible for setting up manufacturing schemes for production of candidate viruses which would cause cancer. And then later on in my career, I went to work at a Frederick laboratory called, sorry, slipped my mind for a minute, in which we were we were being asked by the United States military to develop vaccines to prevent military against infection from viruses and other microbial agents. And it was at that time that I got into the process of manufacturing vaccines and understanding the regulatory affairs of regulatory regulations of the Food and Drug Administration that govern the production, testing, and administration of vaccines. So that sort of is a thumbnail sketch of my background.
That sounds like a pretty amazing reason why we should be talking to you here today. So what exactly is a virologist? And what role does that play? And what role does that play in understanding what this the coronavirus is and the future of this disease?
Well, being a virologist allows you to have the basic understanding of how viruses infect and replicate in cells, how they cause disease, how they are spread, and what we can do in order to prevent or to treat virus infections in not only humans, but in any animal host that this virus would display as a disease.
Okay. So earlier in this semester, we defined characteristics of a living organism. Would you consider a virus a living organism?
Absolutely not. By definition, a virus is non-living in the sense that any living organism is able to replicate on its own or reproduce on its own. So if we look at this at the level of the single cell, a cell has the capability, whether it's an animal cell, a plant cell, or even something like a fungus or bacteria. Each of those types of organisms has the capability of reproducing itself. The virus does not. The virus must seek a host to enter, capture or take over the metabolic machinery of that cell, excuse me, and then reproduce. So a virus is not living. It doesn't meet the definition because of a living cell, because it's not able to reproduce on its own.
Okay, great. Thank you. So what is the severe acute respiratory syndrome coronavirus, what we're calling the SARS-CoV-2, and where did it come from?
Well, if we look at the terminology of the virus, we can better understand its nature. This virus, which is referred to as a severe acute respiratory syndrome virus, in fact causes severe or very acute, meaning very sick, disease that is contracted primarily into the lungs or the respiratory system of a host. So it's in that part of the host that the virus is able to replicate and is able to manifest itself in the form of a disease. Now, you asked me, where did it come from? Okay. Well, first of all, it is genetically related to some other coronaviruses that are in the coronavirus family that have been epidemics in the recent past. MERS is one, meaning Middle East Respiratory Syndrome, and SARS, which was another one that came about back some years ago. But what is unique about the SARS-CoV-2, or what we refer to as COVID-19, is that it appears that it has come from a laboratory in Wuhan, China. And that seems to be the source of it. Now, how did it get into that laboratory? Most likely, the investigators there were investigating the natural history of the COVID viruses, and was doing what we call some host range studies to see whether or not this virus, which was probably isolated from a wild bat, what type of cell it replicated in, and learning more about the molecular biology of it. So while the predecessor of the COVID-19 may have originated in bats, most likely this particular isolate came from that laboratory in Wuhan, China, where it was being investigated, probably with all good intent to learn more about the molecular biology of these viruses.
So we don't think it was from people eating bats then? We think it was actually being studied in the laboratory?
Yes, I think that there is sufficient evidence at this point that they were studying the molecular biology and infectivity of the coronaviruses in that laboratory. And the likelihood that somebody ate a bat and contracted the disease, to me, is very unlikely, because first of all, if that bat, and I just say this sort of tactfully, if that bat was carrying the virus, and let's assume it was, even if the bat were eaten raw,
right,
probably the virus would have been killed in the stomach of the individual. The virus would not have entered the lungs of that person, made that person infected, and then allowed that person to transmit the disease. It's possible, but it's more likely that it was a laboratory isolate.
Thank you for clearing that up. I know there's a lot going on, or about rumors of how things got started, and I think it's good to be able to have some more information on that as well. So how is this virus similar to other common viruses that are spread during our normal flu season?
Okay, well, as we're all probably very familiar, the common cold and the flu viruses are spread generally during the winter seasons when people are indoors and they're in close proximity to one another. So this virus is spread in much the same way. It's spread from an infected person coughing or sneezing or having the virus on their hands, and then they hug somebody else or they touch somebody else, or they can contract it themselves by touching the surface that has the virus on it. And then they rub their eyes or, put their hands close to their nose, and somehow the virus gets into that moist surface and then enters the respiratory system. So it's very similar in the way that it's spread and contracted to other viruses that are horizontally transmitted, like the flu or the common cold.
Okay, so then how is it different?
How is it different? It's my understanding from trying to keep track of why this virus appears to be more lethal, which we would refer to as pathogenic in medical terms, than other viruses, is because it not only attaches to the upper parts of the lungs, which is normally where most respiratory infections occur, because if you think about the respiratory system, the first thing that air passes through is going to be the throat into the bronchus and then into the lungs. Okay, so most respiratory viruses will attack the upper portions of the lung. It's my understanding that COVID-19 infects all of the lung. And it attaches specifically to receptors that are on the very tiny alveolar cells in the lung. And it targets that. Rather than it being an inflammation, it's a full-blown inflammation of the entire lung.
Okay. All right. So how can this coronavirus be transmitted? So we've talked about sneezing, getting, putting our hands close to our mouths. Can it be transmitted through mosquitoes? Can it be transmitted on surfaces? How does it stay alive? All of those kinds of questions.
Okay. Well, it's primarily spread what we call directly through a cough, a sneeze, or something like that. If you think about a cough or a sneeze, it's minute particles of moisture that are expelled. And this virus likes moisture. It doesn't dry out in the moist environment, such as in the lungs. So if I sneeze, those particles that you can't even see because they're so small contain the virus. And if I'm close enough to somebody else or close to a surface, those droplets that contain the virus are going to be deposited either on that person, on your hands, or on a solid surface. So as long as the virus is in that moist state, it can survive, and particularly if it's spread directly from one person to another. Now, if it's on a direct surface, and one of my friends gave me an example, he said, couldn't you contract it from the gas pump handle? And I hadn't thought about that, but in fact you can. It's a solid surface, and so if the person that goes to the gas station before you has the virus, coughs on their hand, picks up the gas pump handle, the next person that comes along gets it on their hands, and before the virus has a chance to dry out or become inactivated, it's spread from person to person through this inanimate material, like the gas pump handle.
Okay, right. So So we know the virus requires a living cell to complete the replication process. How is this virus equipped to match the protein receptors of a healthy cell? And we talked about within the lung that it's looking for cells that are in that lining of the whole lung. What's going on with those cells that are so susceptible and receptive to this virus?
Okay. Katie, before I go forward and answer that question, I did not answer one of your previous questions, and that was, can this virus be spread by mosquitoes?
Oh, yes.
There is no evidence forthcoming that the virus can be spread by an invertebrate like a mosquito, much like many other viruses are, because viruses that are spread by mosquitoes have to be able to acquire the virus from an infected host and then immediately bite another person who is naive. And so those viruses that are spread by insects come basically not through the lungs, but through a bite.
Okay. And so I guess then it also can't be spread through blood, pathogen, blood transmission, that sort of stuff.
I would say not. Now, I think that at one of the president's briefings, one of the doctors, one of the specialists was asked that question. And as I recall, the doctor said, no, there is no evidence at this point that it is spread through blood transfusion, much like AIDS would be spread or HIV.
Okay. Yep.
So you were asking about the living cell and why that's required for the virus to infect. If you were to look at this virus under electron microscope, and there's been plenty of pictures on the internet of what this looks like, and of course, it looks like a shiny ball with these funny projections sticking out of it. Those we refer to as spikes. They're not pointed, but they are projections. So classically in virology, we say that these projections on the virus surface are called spikes. Those particular spikes are proteins, and that protein has a very unique affinity for receptors in the lung cells. So when it enters the body, it searches out a susceptible cell, and it uses those spikes to attach to the exterior of the lung cells, or the exterior surface on the inside of the lung.
Okay. So what is the physical impact of COVID-19 disease on the human body? What is making this so dangerous?
Well, I must say that when I first heard about COVID-19 and started to hear about the various ways that they diagnose COVID-19 as compared to the flu and common cold, there were just a few symptoms, so to speak, that they were relying on: coughing, fever, fatigue, some things like that. But lately, they keep adding more and more symptoms because there are certain patients that are presenting with these additional symptoms, and lo and behold, when they test them, they are infected. But basically, the symptoms relate to what part of the body is being infected. So if it is the lungs, which is the primary target, of course, the person's going to have difficulty breathing, and they're going to be coughing because there's a lot of mucus, etc. And there's going to be a fever because it's inflammation throughout the body. And fever is the body's response to infection of some sort. So, but what concerns me is that here in the last couple of weeks, there also appears that the virus can target, in some people, the heart. And that may be the cause why some people are literally dying of heart failure, not just from the other manifestations of the disease.
So,
Well, I was just going to conclude. So I think that you asked me, why is it so dangerous? Well,
right.
it is so dangerous because it basically is, using the layman's terms, it's suffocating the individual because of the severe reaction to the virus throughout the lungs. And if it's also affecting the function of the heart, the person is, you know, going to die either of,
We need that.
yeah, one form or another.
Right, right. Okay, so just to confirm, anyone can catch this virus. It's
Yes.
the greatest public concern is how each individual is going to react to this virus. Is that
Okay, go ahead.
okay? That's pretty much the question. Is that the public concern is that there's going to be more vulnerable populations?
Yes, most certainly. It doesn't appear that there's any exceptions to the rule that some individuals are resistant, so to speak.
Mm-hmm.
We don't know yet, however, um, what the prevalence is of people who are infected but do not show any symptoms, the so-called asymptomatic person. But to summarize the first part of your question, I think that anybody can catch this virus.
Okay.
Some people will be more resistant than others, and we can talk a little bit later as to what those factors might be.
Okay.
But I think that the perception of some people is that this virus is no more serious than the flu.
Mm-hmm.
And it may be the case. However, there are segments of our population, like the elderly or people who are immunocompromised, that really do need to fear this because it is life-threatening.
Mm-hmm. So you've mentioned the elderly, immunocompromised, maybe pre-existing respiratory issues like asthma, that those folks are really at great risk. Are there any more determinants of who's going to have a more severe case of COVID-19 that have been coming out through as we've seen it develop over the weeks?
I think that there will be more and more. I think that we will find the people who have had other types of diseases, maybe are overweight, are in stressful lifestyles, are malnourished, and even maybe genetically predisposed,
Mm-hmm.
are going to be more likely to contract it or at least have a serious infection. At the same time, and we might also talk about this a little bit later, I think that we will find that there may be some people that are genetically more resistant. And that wouldn't be unique just to this coronavirus. There are other virus systems and other even bacterial systems where the genetic background of an individual either predisposes them or makes them more resistant to certain types of diseases.
Can you expand upon that a little bit more about that genetic resistance or susceptibility?
Well, yes, I can do that in the sense of talking about the two major aspects of our immune system. There's what we call the natural immunity, and then there's the other one, which is called the acquired immune system. So in the natural immune system, we all have, for example, white blood cells that are circulating through the bloodstream looking for foreign pathogens, so to speak, things that don't belong there. And sometimes it's just an allergy because our bodies have not been previously exposed to some type of an allergen. And so we have an immune reaction, and that's our natural immune system. And that's different than the acquired immune system, which means the immunity that develops after you've had an infection, as in the case of the coronavirus.
Mhm.
Now, what we don't know yet about the coronaviruses is that some person's natural immunity might be heightened enough because of their nutritional status, their genetics, their exercise, the fact that they have not been, they're not a diabetic, or they haven't suffered some other types of trauma, whatever, um, they might be very resistant.
Mhm.
And so when they acquire the virus, they might have sniffles for a few days, and they just sort of dismiss this as, well, I must have just contracted something. And in
Mhm.
fact, it's coronavirus.
Right. Okay. Um, so I want to start going towards, now that we have a good understanding of what this virus is, how it's different, but start talking about how are we testing for this virus. So Governor Hogan and First Lady Hogan secured 500,000 tests from South Korea. What does that mean for the people of Maryland? Who is going to be tested, and what are they testing for?
Okay, well, first of all, we need to assume that these tests are reliable. So I'm going to say, let's assume that the tests that we purchase or we receive from South Korea are reliable. And I have no knowledge otherwise that they are not. But having these tests in the hands of our governors, and in particular the governor of Maryland, is going to allow the state government to make decisions as to when our businesses can open and when our citizens can resume their activities. Although each state is going to hopefully follow the president's guidelines and the phased-in guidelines when the governors reopen the state. So I think that this will be very helpful for the governor of Maryland to know when it's going to be safe to open it. Now, the tests that have been described sort of generically on the daily briefings are basically of two types. One is testing for the presence of the virus itself, and in particular, it's for the virus's nucleic acid. That is what most of these tests that we're getting from like South Korea and some of the other manufacturers. They are tests just to see whether you are a carrier or you have been infected with the virus. And it's a simple swab of the nose, or maybe it's a swab of the mouth or something like that. The second type of test, though, is testing for antibody, which means you have been infected with it. You may not have realized it, or you may have come down with symptoms, but you're being tested to see whether you have antibodies as a result of your interaction with infection by the virus. So that type of test is going to take much longer to get disseminated among the population, because once that blood sample has been collected from the individual, then it has to be tested. And that can be done very quickly. But to disseminate those tests throughout the country in large populations is going to take some time.
So why has it been so challenging to be tested for this virus?
Okay, well, there's a couple of factors that have played into the difficulty in doing these tests. First of all, there was a very limited number of tests, and particularly reliable tests, that were available in the United States. And we've all heard the President talk about the fact that the country was not geared up to do testing on a large scale.
Mhm.
And so once these tests began to get accepted and manufactured at an extraordinarily high rate, that those tests were needed primarily in states where there was the severity of the disease. So as an example, most of those that were quickly manufactured were going to New York and to California and some of those places where there was really a high outbreak of the virus. And then the next difficulty would be to, once these tests were available, get them distributed to various parts of the country, particularly the rural parts of the country, and having staff there that would be trained to administer the test. So it was, I think, a really great step forward when they moved from having to go to a hospital or some drive-in facility where some trained person would swab your nose, etc. And now they have a self-administered type of test. So that's been a great moving forward. But each of these things has really slowed things down in terms of how long it would take to test a major population.
So, do you suspect that we will see a correlation of increased positive cases with increased testing?
Yes, I do. First of all, let's talk about the two different types of tests that I mentioned a few minutes ago. If we're testing for the presence of the virus, we're basically looking to see who currently has the virus.
Mm-hmm.
If we're testing for the antibody, we're testing for who had the virus.
Mm-hmm.
And so that's the two differences, basically. And so our epidemiologists, such as we've heard on the daily briefings, don't really break that down and say, okay, we're testing these places and this number of individuals for the presence of the virus, and this number of people in these locations for antibody to the virus. Nonetheless, they are putting all of this together as epidemiologists so that they can better have a picture of where the virus is being spread, how many people have contracted the virus, how many people are still suspect or susceptible to getting the virus. And so until they've amassed all of that data, and it's being done really at a phenomenal rate, if you just follow what we hear on, through the media, there's a lot of testing, and we're making a lot of headway.
Great.
In fact, that's the way that they monitor whether the curve is going down.
I want to ask you more about that in a little bit.
Okay. Yeah, sure.
Yeah. So do you think that an increase in that correlation of people being tested positive, do you think that will be due to the number of people who are actually being tested, or because there is an increase in the cases? And how are we going to know the difference between people being tested and more people being infected?
Well, first of all, I think that we will find that there are a lot more people infected than we suspected. And so if you were to look, and I'm sure you've looked at the daily number of cases, the number of fatalities versus number of infected. Those data are all based on the numerator being in number infected and number died, and the denominator being the number of cases that have been presented. It's not based on on total population. So I do think that the number of fatalities and the number of overt infected is going to go down in terms of that ratio. Now, let's see. So I guess the second part of your question is, will there be an increase in the future? Yes, I think that there will continue to be an increase in not only the number of individuals who contract the disease, because until we get a handle on being able to stop it, there's going to be more and more cases. But I think we will also see that ratio that I just talked about go down, because we'll find with our testing that there's a lot of people that have been infected that have not come down with the disease. And so the fatality rate will decrease.
So how has this virus changed since we first started observing it back in September?
Okay, if you mean has it changed genetically, I
Mm-hmm.
can't answer that factually. I cannot say yes, there's evidence that it has. But knowing what I know about, from my training about viruses, they constantly mutate or they constantly change. In fact, there's some classic studies that we were using in our biology courses at FCC, in which you could determine the rate of mutation of a virus in a matter of days. And so the first part of your question is most likely it has changed because, like any other organism that evolves in time, it evolves through mutation. But if you're asking me whether the virulence or the pathogenicity of the virus has changed, that too is possible, but it's far too early to know that, because basically what we are reporting are how many people are getting infected and how many people die, et cetera. And we're not breaking those data down. We will eventually.
Mm-hmm.
And what is in favor of the fact that the virus has changed is that they've done genomic sequencing of the viruses that may have come into the West Coast, California, state of Washington, et cetera, and compared it with what has come into New York from Europe on the East Coast. And there are a number of sequence differences, so they can discriminate between those two types of COVID-19 virus.
Wow, that's really interesting. So who is working to develop a vaccine? And since there's two different strands, are they working on two different vaccines? Or
Well, a number of different pharmaceutical companies, and I will mention Johnson & Johnson, not because it's a favorite, but because they were one of the first to get started on it. I would say there's probably a dozen, and I'm just using that term loosely, a dozen different pharmaceutical companies that have their own candidate vaccine. When I say it's relatively easy to manufacture a vaccine, I don't mean that in terms of ease of getting it ready for use.
mm-hmm.
The laboratory portion, the in vitro or the tissue culture portion of that vaccine development is relatively easy. So let's just say there's a dozen companies that's they want their vaccine to be the one that's accepted, because there'll only be one.
Right.
May not be one universal, but there'll only be one in the United States. I know that from my experience working with the Food and Drug Administration.
Okay.
And they will do what's called a down select of that vaccine of these various from these various companies. Mm-hmm. And so that vaccine that is chosen has to have two basic qualifications. One is it has to be safe. In other words, it doesn't cause disease on its own. And it has to be effective, and we call that efficacy testing. And so that means, can it sufficiently protect an immune naive person from getting COVID-19 virus infection? Mm-hmm. So the vaccine has to meet those two primary standards. Now there's other standards, which I can also mention, but those are the big two, safety and efficacy.
Okay, so to meet those two basic standards, how long is it going to take one of these companies to create a vaccine that is accepted?
Well, vaccines take several years to develop. If you want me to compare it with the development of the annual flu vaccine, I can do that. But let me give you a contrast. Okay. One of the companies that I worked for worked with for over 10 years, was responsible for developing vaccines against some infectious diseases, such as Ebola, smallpox, etc. The development of those vaccines took almost a decade, 10 years. Now, with a virus such as the coronavirus, there are sort of two things that are in favor of a much shorter period of time. The fact that this virus is much like the flu virus, which basically gets a new form of the flu virus gets manufactured and licensed every year to meet whatever the new mutant flu virus is for the year. That's done basically within a year's time. And so it's going to take about a year to get the coronavirus accepted and approved by the Food and Drug Administration. Now, there is in the Food and Drug Administration a policy called fast tracking. And obviously, because this is such a severe pandemic, the Food and Drug Administration will bend over backwards to fast track this. But it still must satisfy the criteria that the Food and Drug Administration has, and that again is safety and efficacy.
Okay. So what will be the process of releasing this vaccine once it has passed through FDA?
Well, I may have hinted to that in your previous question. So I will sort of review the steps that it takes to license a vaccine in terms of phases. The first phase is that you test your vaccine candidate in an animal model system. Now, that might be in primates or it might be in some other type of an animal model. And that will take several months to show that this vaccine will prevent a disease in an animal model. Then it goes on to the next step, and that is what we call phase 1, which is a very small safety trial in humans, such that if they administer the vaccine to a healthy small group of individuals, and if those individuals do not get any fever, chills, headaches, or anything like that, it's deemed to be safe. Then it moves into what's called small efficacy testing. In this case, they would administer the vaccine that they know is safe, and they would sort of challenge that person with the virus, and if it is effective in preventing that, an outbreak, or the sickness in that person, then it would be ready to go into a large scale. And in that case, conventionally, what you have to do is administer the vaccine to a naive population in an area of the world where those individuals would contract the virus.
Okay.
And I'm not sure about the logistics for the coronavirus, whether that would require the vaccine to be tested first, let's say in South America or someplace else where the time of the year is the coronavirus is more prevalent. I'm not sure about that, but hopefully we can understand that sequence of those types of phase 1, phase 2, and large-scale clinical trials are required before the Food and Drug Administration are going to say, yes, we'll use this vaccine. And then the manufacturer has to manufacture millions of doses.
So that's
that does not take long.
So who will receive this vaccine once it's first approved? You're saying maybe South America. Why would that be?
Well, I think that my reference to South America was only that they would receive it in for clinical trials. But in terms of use of the general public, I cannot, accurately answer that question other than knowing the strategy that's used in protecting the general public with the annual flu vaccine. Most likely, the first persons who would get that would be the elderly or persons who are at risk because they're immunocompromised and they have heart disease, they have, diabetes or, just, some other form of immunocompromise.
Okay, so how will herd immunity play into the vaccination process?
Well, first of all, let me define herd immunity. Basically, what it means is that if a herd of cattle or herd of horses or herd of people are living in close proximity to one another, if 90% of them are immune to a particular disease, it's less likely that that disease, whether it's a virus or even some other kind of disease, will have a chance to take over and infect or make sick many individuals. So that's what herd immunity is. And classically, we've used that approach in eradicating or at least reducing the incidence of diseases around the world. And poliovirus is probably, and smallpox virus, so those were, deadly diseases or, incapacitating diseases at one time. But the development of vaccines for both smallpox as well as for polio and a number of other diseases has created that herd immunity. So we don't have to be afraid that we're going to contract polio virus if we go to the swimming pool, or smallpox virus if we're, around anybody else that has something like that. So that has been the most effective way of preventing epidemics or pandemics is herd immunity. And so I've already given you some examples of that. So in terms of herd immunity in our country, that could come either naturally in small groups of people who have contracted COVID-19, or it may come as a result of vaccination of naive populations.
So what happens to herd immunity if people choose not to receive this vaccination?
Well, there'll be potential for another outbreak, very simply. There's been this sort of stigma that vaccinations are bad, but there's been cases where people have resisted having their children vaccinated for whooping cough, and then the child gets whooping cough. Or they refuse to have their child vaccinated for tetanus, and the child gets tetanus. So there's pros and cons. I mean, I would say, from my experience in vaccinology, that there's no 100% guarantee. There's no way of guaranteeing that 100% of the people who receive a vaccine are not going to have a side effect from it. But that vaccine would not have been released by the Food and Drug Administration if it were not proven to be highly effective and safe.
Okay. So does the government then have the ability to regulate the vaccine to to increase that herd immunity and to lower social restrictions? Like we see for elementary schools that children have to be vaccinated to be able to go to school unless they have a written piece. Is the government able to do something like that to require people to receive a vaccination?
First of all, I would say, yes, the government through the FDA has that authority. Now, I'm not sure to what extent that's going to be used, that leverage, if you want to call it that, or that authority is going to be used when it comes to COVID-19. I'm sure that if there are some individuals who maybe for religious purpose, reasons or something like that, would refuse, um, I'm not sure whether the government would be able to say, no, you must have it. But I think that the government will evoke a herd immunity type of mandate.
Okay.
That all persons who are either of a certain age or a certain, health condition need to receive it.
Okay. So while we're waiting for this vaccine to be created, what we can do now is what they're saying is wash your hands. That personal hygiene is going to be one of our own personal biggest ways of deflecting this virus. So why is hand washing so effective in killing the virus?
Well, let's just talk for a minute about the structure of this virus. This virus has the very interior of the virus is its nucleic acid, or its means for reproducing. Surrounding that is a lipid or fatty coat. And then on the very surface of that are these protein projections that stick out, these spikes, as I referred to earlier. Both the lipid coat and the proteins are very subject to denaturation. And we tell that to we talk to our students in biology at FCC about the basic molecular structure of life. And that's lipids, carbohydrates, nucleic acids, and proteins. Well, the things such as that we interact with on a daily basis, like soap and detergent and disinfectants, simply denature the protein and dissolve the lipid coat on the virus. And without that lipid coat, or without those proteins on its surface, the virus has no way of infecting a cell. And so this very fundamental thing that we learn as a child about wash your hands before you eat, and things such as that, is the major deterrent to keep from infecting somebody or being infected.
Okay. I have a question that came in about warm weather, that as we get into the summertime, will the warm weather be able to do anything to get rid of this virus?
Remember, the warm weather brings people outside to assume their daily activities. There's less close, I'll call intimate contact between individuals. I mean, such as the contact within a family. I mean, you're not hugging and shaking hands and kissing your family, etc. Okay. Now, the exception to that is that even in the summertime, there are times where we are in crowds. And I'll use as an example a crowded football or soccer stadium or something like that. So the warm weather brings us outside, but we still need to be careful how close we get to one another. But because there's this reduced close contact, which is, as I mentioned earlier, required for spreading the virus directly from one person to another, it's less likely that that close contact is going to happen in the warm weather when we're outside. Also, the virus is very labile, or very, very susceptible to being killed by the ultraviolet rays that's part of the sunlight, and particularly on a solid surface. So, for example, if somebody had a picnic box, an insulated, drink container or something like that, and the surface were contaminated, but that container is sitting out in the sunlight for a half hour or so at the beach, at the swimming pool or something like that, any virus that's on the surface of that solid surface is going to be inactivated by the ultraviolet. So those are two reasons why the warm weather, summertime, less likely. And then the same always applies with the common cold. The incidence of common cold or the flu in the summertime is much lower than it is in the wintertime for the same reasons.
Great. Okay, thank you.
Yeah.
So let's look a little bit closer to home. And when we look at Frederick County, where is Frederick County on our projective curve?
Well, for the last week, I have not specifically followed where our county is on the infection curve. But seeing that we are several weeks behind New York and New Jersey, I'm sure that there will continue to be an increase in the number of cases in our county as well as in our state. But I have a lot of confidence in our governor that he will wait until he sees the peak go down before, and particularly the peak in the metropolitan area before he opens up the state. I know that there has been some relaxing to some degree in the state of Maryland, but I still think that that's several weeks away.
Okay, okay. So in relation to historical patterns of viruses running their course, will there be other spikes in the number of positive cases in the future?
Yes, most definitely. As with most other diseases that are horizontally transmitted, that is, transmitted from person to person, there will be pockets of new infection as infected individuals begin to travel about and come in contact with other naive persons. You know, once people feel free to travel, you know, across the country on summer vacation or to go to Europe, once these other countries open up, people want to get back to normalcy. And there's bound to be some carriers. But, you know, the best thing that we can do is the social distancing and the testing that's going on, because it's going to be quite a while before we have a vaccine that's going to immunize major populations.
So you think we could see this quarantining going on for a while? What does a while look like?
Not being an epidemiologist per se, but knowing something about the spread of diseases, I think that while some of us may get back to some degree of normalcy in maybe in the early part of the summer, I can see that other parts of the country and small pockets of groups of people will have these outbreaks, and hopefully they'll be able to control that with medications. That there's a number of drugs that are being tested that show favorable response.
Okay.
Now that we have the respirators and we've got people conditioned to the way they do things, I'm optimistic that we can control these outbreaks.
Okay. Have researchers noticed any patterns in how this virus is spreading through communities?
Well, we learn new things about this virus every day. I try to follow the briefings, and I try to follow what's on the internet. And I think that the more serological testing and contact testing that we are doing, the more we're learning about the ways that this virus is capable of spreading. As an example, even knowing now that even knowing that tigers and lions are being mammals, that they might be susceptible, I was quite surprised to learn that a number of these wild animals, as well as some domestic cats, have contracted the virus. Now, I don't know for a fact that they come down with, you know, fever and chills and coughing and things like that. However, I did learn yesterday that some of the tigers, I think they were in the zoo in New York, actually did have some lethargy and coughing type thing, and so I guess they were tested. But humorously speaking, how does a lion get close enough to an infected human to be able to contract the virus? So when when we say we know everything about the virus spread, we still have to answer those questions about how animals such as this have contracted the virus.
Right, right. So, in your research as a virologist, did you study the social stigma that's associated with virus outbreaks? How can that help stop the stigma that people who are getting this virus have poor personal hygiene, or patients are unclean, that is being associated with contracting the coronavirus?
Let me answer the first part of your question this way. Yes, as a virologist, we did study those aspects, particularly when I was involved in the development of an understanding of how the HIV is spread and the AIDS disease. Most definitely there was a social stigma to that. You know, it was confined to people who practiced, you know, freely practice sex and drug users, etc. So there was always that social stigma that was attached to HIV, that the person must be doing some of these types of social activities in order to contract it. And the same way with Ebola, when I was working on the development of an Ebola vaccine. Of course, Ebola there were these outbreaks of Ebola, and it was always in a third world country, Africa or something like that, where people were being, you know, either eating or coming in close contact with animals that were carrying it. So in those two examples, there definitely is a social stigma. But I'm not sure that we can even attach a social stigma to COVID-19 or any of the coronaviruses, because this virus attacks all ages, all races, all religions, all social status, from the rich to the poor, from the, you know, the Native Americans to the highly prosperous individuals. And, you know, I use for an example Tom Hanks. You know, I think that the reason that there was such a degree of reporting about Tom Hanks was to show that a movie star, a wealthy movie star who's in Australia with his family, can contract COVID-19. So I think it's up to the media as well as each of us citizens not to look down on somebody because they either contracted or died or came in contact with it. That's you know, inhumane and goes against all my, you know, religious teachings.
Mm-hmm. So does the stigma slow progress towards a vaccine or reopening of communities?
Yes, it certainly will. That stigma will slow us down, because people they may not want to take the vaccine. They may not, you know, want to associate with certain groups. And I think it's going to take a combined effort between social workers, the doctors, the medical community, the educated, etc., to try to dispel or dismiss the social thing, which is really not a factor, because from the very rich to the very poor, and regardless of what part of the world, two individuals come in close contact with one another can spread this virus. It has nothing to do with their social status.
Okay, thank you. So when looking for information about the latest scientific and medical updates, what are some primary and secondary resources that you would recommend?
Well, I will mention what I do on a daily basis, and that is I go to coronavirus.jhu, that's Johns Hopkins University, at edu/map.html. That's been my primary daily source. And then I also read anything that I find on the internet that I find is a scientific report. When I watch the daily briefings from the White House, I don't focus on what the president is saying because he comes from a different environment than we scientists. I do listen very intently to Dr. Fauci and to Deborah because I trust them. They are esteemed scientists, and some of the other members of the task force that have the medical or the scientific background. And I've learned a lot from those briefings, and I've been able to follow up on my own questions by searching the internet.
Mm-hmm. So with so many opinions being broadcasted, how do we decipher a scientific decision-making from pseudoscience, and why is that important in this while we go through?
Well, Katie, I find that to be a somewhat difficult question to answer.
Yeah.
And so I trust my scientific judgment and my experience to guide me in my interpretations. I think it's very important these days that we remain apolitical and that we remain open-minded, and before making judgment, and that we use what I would call qualified internet sources to validate our thinking. In other words, don't let the news media simply be what you judge whether something is right or wrong, or whether it's accurate or not. We all were particularly, and I'm talking in this case to our students, that we're all been given the intelligence to be able to pursue a better life, and part of that means that you use your God-given intelligence to make your decisions, and that when you question something, that you go to reliable sources and not just to what is the gossip, so to speak, that's either on TV or in your community.
Okay. So do you have any final thoughts about where we are as a Frederick community, or more information, as more information continues to develop about this virus?
Well, I feel that our community, and I'm speaking Frederick community here, is doing the best that we can. And we're doing the best because I see it as and I don't go out in the community a lot, but we do go to the grocery store, we go to the pharmacy, and we go and get a takeout meal or something like that. Everybody that I see is practicing the guidelines that's to keep us safe at this time, wearing face masks. And we also, I think, do ourselves the greatest justice by intelligently listening to the leadership of the coronavirus task force that I mentioned before, and not just judging what we read necessarily in the newspaper, or that we hear in, through Facebook or something like that. Not to say that Facebook isn't a good thing, but sometimes our impression is what somebody says that is ill-informed.
Okay. Well, let's go ahead and wrap this up. So our discussion today has just been so insightful. Thank you so very much for sharing your time and your knowledge with us. I think we could go on and on discussing this, and I think that this is a discussion that grows as we see what happens in the coming months and years. So I really, really appreciate your time today, Dr. Fine. Thank you so much.
Thank you, and I appreciate the opportunity. I've enjoyed my tenure at FCC and hope it will continue, and I feel grateful that I'm able to help at this particular time with our students' education.
Wonderful. All right, well, thanks so much.